Then we come to New Jersey and we bring Dorothea Dix and Thomas Kirkbride. They were both advocates for mental health and the architecture of psychiatric hospitals. In 1848, Trenton State Psychiatric Hospital here in New Jersey was founded by Dorothea Dix, and was the first public mental hospital in the state of New Jersey, and the first mental hospital built on the Kirkbride plan. Dr. Kirkbride's plan incorporated architecture as well as the treatment programs. Trenton State was the first complete asylum built on this plan, and this plan again, went for therapeutic treatment and a gentle architectural surrounding. The moral treatment approach depended on these specially constructed, quiet, secluded, and peaceful country settings, opportunities for meaningful work and recreation, and a system of privileges and rewards for rational behavior. The Kirkbride buildings tended to be large, imposing institutional buildings, with a defining feature being their narrow, stepped, linear building footprint, you can see on the right, which extended out along to allow the corridors to open to sunlight and ventilation at both ends and throughout, which he believed that air and the ventilation and sunlight would help and aid in the healing. Kirkbride also advocated the importance of spacious landscapes again, and being able to have good views of nature. He suggested that the hospitals be a minimum of 100 acres per site, so that they would have a dignity of space. Often, patients, as part of physical exercise and therapy, would be responsible for keeping these grounds. Over the course of the 19th and 20th century, the campuses of these hospitals often evolved into sprawling and expansive grounds with numerous buildings. Trenton's hospital, as large as it was, became overcrowded. And then looking along the bottom there, to alleviate this overcrowding, in 1876, Greystone Park Psychiatric Hospital, or simply Greystone here in Morristown, was built. Originally, it was built to accommodate 350 people. By the time it had reached it had been expanded a few times, it reached 7,700 patients, resulting in unprecedented overcrowding. And as many people probably on this call know, it was demolished in 2015. And then we come to modern times. Modern times mark both the rapid movement with development of psychiatry as we know it today, and continue to have challenges for how mental illness was handled, as well as health of the mind. In the 1900s, nature was still used as an instrument of treatment, though the construction of massive institutions waned. In 1910, we have the example of the Beltmead Farm Colony and Sanatorium, which was founded with the goal of establishing and maintaining a colony for the care of and treatment of sick persons, and in particularly for the care and treatment of those who have nervous and mental diseases or any other allied diseases. The goal was to provide humane personal treatment in a restorative setting. But by the 1950s, the death knell for psychiatric asylums and institutions had sounded. A new system of mental health care, the community mental health system, was developed with the intent of returning those suffering from mental illnesses back to their families and to their communities. In 1955, Congress passed the Mental Health Study Act, leading to the establishment of the Joint Commission on Mental Health, Mental Illness, and Mental Health. That commission issued a report which would become the basis of the I'm going to call it the CMHA also, and was an act to provide funding, federal funding for community mental health centers and research facilities in the US. So the idea of this act was to put money into the communities, put money out there to develop knowledge, and in the end, it didn't work out that way at all. The legislation was passed and led to considerable deinstitutionalization. The purpose was to help in the community, but only half of the proposed centers were ever built, none were fully funded, and the act didn't provide money to operate them long term. And many states saw this as an opportunity to close their expensive state hospitals without spending some of the money on developing community-based care. So, and then add to it the adoption of Medicaid in 1965 to institutionalization deinstitutionalization accelerated. Many patients formerly warehoused in these institutions were released to the community. However, the communities didn't have the facilities or the expertise to handle them. In many cases, they wound up in adult homes with their families or homeless in large cities without any care, without the mental care they needed. So in the 1970s, the residential care continued to diminish. Hagedorn, Overbrook, Marlborough, Greystone, all New Jersey psychiatric hospitals shown above were either closed or demolished. Meanwhile, addiction centers were surviving through the 90s with increased awareness. And just before COVID hit, the opioid crisis and suicide had skyrocketed, which basically brings us to the present. Elizabeth?
Hi, thank you. So where we are today, obviously the pandemic has had a huge influence on behavioral health organizations and people in general. There's been a rise in children, teens, adults, the elderly. It's affected everyone. It's also had an impact on the health workers and the caretakers at home. So with this, we're also seeing a rise in substance abuse, particularly alcoholism, as people are at home during the pandemic. And those with substance abuse issues are having trouble and resistance to go to a treatment location because of COVID. So how do they detox appropriately, safely at home? But there's been, one positive thing I think that's been coming out of the pandemic is obviously this shift towards telehealth and the approvals for reimbursements that made this possible. And this has also put a strain on the institutions to be able to manage the data and to put those systems in place to manage not only the care and the providers being able to provide care through the community. It's also managing the records. So that was a positive thing. Next slide. So, I wanted to talk a little bit about some of the statistics, which I think is important to really understand. There's about 1 in 5 adults that are affected by, mental illness. And that's a pretty staggering number. That's close to home. That's somebody that you know in your network. And that's serious mental illness is about 1 in 20 adults. There's also been a rise in the youths between 6 and 17 who've experienced mental health disorders. And there's also in adults, there's co-occurring substance use and mental illness and substance abuse disorders are involved in about 1 in every 8 ED visits. And so that's having an impact on the facilities that may not have behavioral health settings as inpatient or have the EDs that are structured to handle the mental health issues. So that's something that we're all kind of taking into account when we're thinking about the future. And mood disorders are the most common cause of hospitalizations. Depression and anxiety cost the global economy $1 trillion in lost productivity each year. And I think that this is impacting workplaces that are now addressing this and how they can help people cope with, their workplace. So they're providing those services. Depression is the leading cause of disability worldwide. So this is not just here in the US. And serious mental illness cause 193 billion in lost earnings each year. Something to keep in mind. And it's not just, the people, that you work with, it's people, there's the homeless, the veterans that are also have mental illness, about 40%. There's people who are incarcerated. There's about 37% of adults in the prison systems are diagnosed with mental illness. And also the youth, 70% of the youth in juvenile systems are also diagnosed with mental illness. So these are staggering numbers. And, you know, people like Erin and Kimberly, who are very passionate about behavioral health, you know, this is why they do and what we do, because it's what we love. We want to help people. So next slide. So I think there's been an increase in awareness, and there's a decrease in the stigmas around mental health. We're trying to provide more accessibility in the communities, in the hospitals, through telehealth. I think that the awareness and being able to treat people in the communities has certainly increased. So as a result, you know, I think as a shift from what Erin was talking about historically, the destigmatization of mental health and the facilities, we're trying to provide a more positive point of view, having a more welcoming environment so you're not going into something that's so institutional. You know, creating more efficient and effective planning arrangements that are safe, which we'll go into more detail later in the presentation. Education and research are on the rise for organizations that are providing these services. We know that testing is also on the rise to help diagnose and treat the conditions with medication in a more effective way. And then providing amenities for people, so it's taking away from you know, a typical inpatient unit. We're providing things that we know are proven evidence-based design for wellness. Next. Next, Erin.
Trying. I hope it's not frozen.
We've got a.
Bear with me.
We have a lag there.
There we go. Lovely.
There we go.
So, you know, hello, New Jersey colleagues. It's such an honor to be here with you today. And, you know, just tagging on to what Elizabeth was talking about, I think, you know, the pandemic, if anybody can look to find a positive in the pandemic, I know it's been such a dreadful time for all of us over the last couple of years, but the stigma, we have destigmatized mental and behavioral health in our communities. We're talking about it. And we all recognize now in a very open way, it's okay not to be okay. So, you know, this really has shone the light brightly, and for somebody that spends every day, all day, focused on the design for the mental and behavioral health environment, we are delighted that this change is taking place and that we're all moving forward in a very positive manner for our loved ones. So this segment of the presentation, I'm going to focus in on the safety aspect of it. This is a CEU, and in order to get our health and safety and welfare portions, that's what I've been relegated to do. So I'm going to start out with the definition. And if you see here on the screen, the Joint Commission's definition of ligature resistance, in most hospital organizations that are Joint Commission accredited will be surveyed through this definition. And then the FGI 2018, putting a plug in that 2022 is on its way out. And there are some changes in 2022 with the particularly the emergency services and for the chapter 2.5, but you know, we can do everything that is possible to get a completely ligature resistant environment. But, you know, you cannot replace the value of the staff observation, the interaction with the staff, with the patients. And, you know, if a patient is determined, they're going to find a way to be successful. So, you know, we often hear people say anti-ligature. And if any of you have worked with me, you're going to know real quickly, I often speak up and go, you know, there's not anti anything really. It's ligature resistant. So that's what we try for. We try for a ligature resistant environment. Next slide, please. So, you know, so what are we talking about in the built environment? This next slide gives a listing of when we're coming through looking at peer review and design or talking with our colleague architects and or organizations. These are the points that we start to pay very close attention to. And you know, up until lately, the floor drains were not, standard floor drains were not cited by Joint Commission, but we're beginning, of course, when events happen, situations change, and we're starting to see the floor drains being called out as a ligature attachment risk, and particularly concerned about a gator roll scenario. So here are just a few items. I won't go into much detail yet on these. Next slide. So when we look at the patient areas for ligature resistance, we kind of take two approaches. But first and foremost, our guiding principles on everything that we do for a mental and behavioral health environment of care is safety. Is the environment safe for both patients and staff? Therapeutic. Does it encourage a therapeutic response for the patients? And is it therapeutic for the staff to be working in this environment? And does it support restorative health? Does it? And so how do you incorporate that and not to look strongly institutional in a very hard environment? So these are some of the conversations that we have with our designs and our process. Next slide. So let's step back and look at the patient bedroom. So, you know, oftentimes we're meet with our clients and they've taken a med surge and converted it into mental and behavioral health. And I often say that is probably one of the most challenging retro and repurposing that you'll find, because med surge units are designed so that everything with the patient occurs in the bedroom. The majority of their time is in there, sleeping, eating meals. They get their care in there. Their providers visit them in there, their family visits them, and they have their TV and medical education that goes on within their bedrooms. Well, in a behavioral and mental health environment, that is very, very different. Basically, the only activities that are occurring in the bedroom is sleeping and bathing and grooming. So that takes on a very different meaning and design for a patient bedroom for mental and behavioral health. Next slide. So when we're looking at the design of the patient bedroom, there are many factors to consider, but just some of the, you know, observation into the bedroom from the door for staff, so that you can alleviate the hidden corners. So, you know, a lot of the old med surge has the inboard toilet, and you've got that hidden area when you step into the bedroom, and that's an area that the patient can hide to create self-harm or to hide to ambush the staff members. So a lot of care and thought to how those rooms are laid out, and the comfort and dignity of the patient. We strip these patients of all of their ability to control the environment. So in the patient bedroom safely, what are some elements that we can do to offer comfort, control temperature, control daylight coming in the room, and other elements within that bedroom without sacrificing the safety? Another item that we often talk about is the single versus double occupancy in these settings. And this is a setting that oftentimes we do see double occupancy versus the single. Usually there's a mix on a unit. So let's keep going fairly quickly. The next slide is just a diagram that was a competition that we developed with the Institute of Patient-Centered Design. We actually did a mock-up of it and published in the Hard Journal with some of the research that we did, but I'm not going to belabor it today, other than to say you can see how when staff members standing at the patient room door, how they can visualize and see the room. Next slide, please. So how do you take these principles, concepts, ideas, and how do you manifest them into design? Well, there are three recognized design guides that are in the marketplace in the industry today. One is the New York Health Guide that I think you all are very familiar with. It's right there in your backyard, and many states have adopted the New York OMH design guide. Also, the VA has a very awesome guide, and both of those guides have recently published updates. And then a document that we publish free to anyone that would like to download it is the Behavioral Health Design Guide. And our guide is recognized by regulatory bodies across the country, but it's not a prescriptive. It's more of a guide, a subjective guide that gives you the experience of my colleagues and I that we have had over our career and how we address the design for the built environment. And we work in this document is closely in alignment with the FGI guidelines. You know, we look to the guidelines as a standard of care within the industry. Next slide. So the last couple of slides, I'm just going to give you some snippets of, and I've got about 2 minutes left, so I need to go fairly quickly. So this is our 5-level safety risk assessment. I will say that this was developed out of a study that was done through the VA, and the colors that are in the matrices respond to a heat map of occurrence. And it's based upon the observation of the patient in various areas within the unit and the suicide ideation of the patient. And we have developed the 5 risk levels based upon the response of the patient and the response of the staff. So for example, level 1 is an area where the patient never crosses the threshold of the door, they do not enter the space, versus level 5 is a special condition when the patients are highly agitated. So I would be delighted to go into any additional detail with anyone later if you would like, based on the definitions. Next slide. So I often get the comments from organizations and architects about using the colors on the matrices. We have found over time that they, when you publish that in a construction document, the colors blur together and you can't distinguish them. So we have gone to a more standardized color scheme that we really try to give the contrast of when developing the safety risk assessment. But this is an example of a forensic project that we recently completed, and the risk levels as we identified them with the staff. This is not the architect developing the risk levels, it is the staff, conversations with the staff. And so the next 4 slides, Erin, just go through these really quickly. This is giving you a standard medical environment. So one of them is an ICU room, and the first look is the environment. The second look, we put the purple dots on where all of the risks are. So, and then here's a hallway of a standard environment, and we've identified where the ligature risks are. And so just finally, just flip through real quickly. These are all excerpts out of the design guide. You know, barricade strategy, every room that a patient goes into, we strongly suggest there be a barricade resistant strategy, and there are multiple ways to do that. The next slide, I like to showcase this because I have had architects and facility guys that go with a piano hinge, and a piano hinge offers a number of ligature attachment opportunities. So this is just to illustrate that. We strongly suggest not using this type of hinge on a door that stays in an open position. The next one is on furnishings, just to be aware that, you know, even your offices where patients are coming to, setting up the furniture, the data and all the elements so that the provider can quickly egress the room when a patient becomes agitated. And then the final last 3 are just some snippets from the design guide on how to treat each of the levels. The only thing to say there is that is the structure of the design guide, that based on the risk level that we help to assist with the conversations during design as to how to treat the ceiling, the glazing, the doors, the furniture, and other specialty items. So thank you all. I feel like that was just, you know, this is content that usually we spend hours on, but I just wanted to give you a snippet of awareness of our approach to the safety aspects of these units. And you don't have to sacrifice you don't have to build an institutional looking facility in order to appreciate the safety. Our vendors today are wonderful. I know Ed was on the phone. If you look at the new facility that his organization just built, that is really showcases that an environment to be safe doesn't have to be institutional in character. So with that, Erin, I'll turn it back over to you guys.
Thank you, Kimberly. Thank you, Donna. See, if anybody on, if I'm not, oh, there's your furniture. We're looking. So actually, Elizabeth, kind of going with the data, Elizabeth is actually going to talk about the principles and try to give some view into how we as architects can take all of this that we've talked about so far, what we've learned and what we're learning and what we know innately, and talk about it. There's a few slides here.
Yes. So, I mean, I think just to tag on to what Kimberly was saying is that, you know, there's much more of a balance from, you know, the critical requirements of safety and security with design now. And so we're going to talk a little bit more about the principles. So, you know, how can we improve the environment? So that's the responsibility of the architect to help improve the conditions. You know, our goal is to create you know, environments that are sensitive, elegant, healing, as well as solution-based. So while we develop the safety standards and best practices, we also do so using design principles that support the therapeutic environment. Obviously through evidence-based design and through over time, we've created viable solutions and tools for well-being. Well building and fit well standards and evidence-based design research proves that access to nature, light, air, calming materials, and forms are not just theoretical tools. So some examples of design principles that support the therapeutic environment are biophilia in nature, circadian lighting, MEP, HVAC, and mastering air quality, particularly through the pandemic, is ensuring you know, higher levels of care through the building systems, balancing open and closed public and private spaces. I think it's really important to give people choices so they're not just confined to their room, that they have the opportunity to, you know, have a choice in the environment that they feel most comfortable in. And so creating a variety of spaces from active to quiet is important. And creating, you know, design features that enhance the environment. You know, also, I think it's our responsibility to provide a balance between the business and the facility needs, always keeping that in mind, and balancing the critical requirements of safety and security. And then support the latest research and evidence-based design principles. So we have a little bit more to talk about in terms of evidence-based design. If you go to the next slide.
Oh,
sorry, there's a delay here. So speaking specifically about biophilia, it denotes the human response to living things and to very special biophilic geometries in our environment. It creates positive effects that come from two distinct sources. The close proximity and visual contact with plants, animal, and other people, and a positive response to artificial creations that follow geometrical rules for the structure of organisms. And so this slide here comes from the Biophilic Healing Index, which predicts the effects of the built environment and our well-being. So this is a great tool that gives you some information. Next slide. So research has found that bodies respond well to the natural cycles of light, and that simulating the natural cycle of day and night can help restore the inner synchronicity that are well that we all are aiming in support of the best care. Next.
Hi.
Erin?
Hi, am I going to jump in here?
Yeah.
Thank you for that moment of silence. So it's 12:42, and I'm going to just fly through a case study of a project that is under construction currently. It's not complete. It's kind of a preview. Phase 2 is just finished. That I think gives a good example of a standard hospital. You know, what like Kimberly was saying, with all the challenges of a standard hospital med-surg building, you know, built for not to be a psychiatric hospital, but having behavioral health units that we have. So the project that I'm going to share with you is a eating disorder unit. It's one of only 2 in the state, and it shows how the principles that we've talked about, along with everything that has to do with safety and security, which protects both the patient population as well as the institution itself. And today, you know, these are requirements. These are providing the best possible safe environment is becoming more and more, you know, reviewed by the state and the FGI, which was a guideline, is now adopted in the state of New Jersey as code. So, you know, it's like I say, it's not even as simple as, you know, if you're jumping from an airplane and the thing says that, you know, you have the option to pull the cord for your, I forget how that goes, but there's a thing, somebody can put it in the chat. It's a requirement now, so FGI is code. This is an eating disorder unit inside of the large hospital, as I said, and I think it shows how the relationship of the mind and body in an eating disorder unit can be integrated. So what I want to say is, when you're designing for behavioral health, of course, everything's important. When you're designing a behavioral health unit for an eating disorder, or for an eating disorder population, there's a whole other line of thinking as well about how to make that population comfortable. And so I think it's particularly interesting also to think about the, you know, the biophilia, to think about the light, to think about the circadian lighting, and to think about how the body can be synchronized, you know, using these elements, and how can space help as an instrument of recovery on this level of being in your body and your mind really fully and synchronized and find your own inner compass. So I don't know if I said that very succinctly, but that's what I think is interesting about this project. So utilizing these best practices, safety, security, dignity, as well as evidence-based design principles and strategies for improving the health of all of the occupants are being integrated. So this photo here is showing the activation of biophilia using nature and light, both actual nature as well as perceived nature. Sorry, that was the teams coming through. So the hospital environment doesn't have, you know, you can't bring green inside because of infection control. You can't have plants. You can't have water features. But so how we can use graphics or artwork, large graphics. On the left-hand side, by the blue chairs, there will be double doors walking out into a future roof garden that will incorporate horticultural therapy, and so this room will be actually sitting next to a rooftop garden. So to say, we're using circadian lighting in this project. So the top left, the light just shows a little hint of a light that changes both for color, so it adds interest, but also is on a circadian clock that ties to you know, the rising and the falling of the sun. So in the morning, this light is rising, and in the afternoon, do not jump out again. In the afternoon, the sun is setting, so to speak, perceptually. This is a photo of the eating area. Right now, the current population is all in one big room with a large table that's used for all multi-purpose puzzles, journaling, so on and so forth. And the room this is the adolescent dining. It actually has two populations, two wings. One is an adolescent, one is adult. This is the adolescent dining area. That window in the back will be also looking to the horticulture garden outside. You see a window where you can see you can be seen from the nurse station, but without, that's going to get a film on it, and without the feeling that you're in a fishbowl. And the last, I have two more. Here you see the idea of movement and comfort, open, flexible space. So we have a balance of the open space and private space. Here you see the the day space, which is the everyday where patients spend their day sitting by the nurse station, but with the open nurse station that doesn't feel like you're being watched. So it feels more like, it has a residential or just a much more dignified design approach to it than having, a glass box. And the right shows how just using some soft, gentle forms can activate the space in a flowing manner that is still calming and gentle. In the back side where that blank wall is, those are the double doors to go out into the rooftop garden. And then here's the patient bedroom. This being an eating disorder unit, these are behavioral health. The patient beds are actually a whole 15-minute conversation in and of themselves. As you saw in Kimberly's, these are not the standard behavioral health beds. These are because of the underweighted patients. Patients are severely underweight. Some of them, they have to be in a completely, they have to be treated differently as far as the bed is concerned. And so this has been shown at Center for Health Design. It is definitely a ligature resistant patient bed, but that's other than that, you can see this is the adolescent wing, so creating interest, but at the same time with calm, a sense of refuge, a sense of place where you can go and sit, and it has dignity and identity, but at the same time has a perceptual evocation of, say, water or air. And then there's custom painted artwork at the foot walls. And the future phase 3, which is going to be in the adult wing, is going to have much more muted colors, but this is because of the age of the population. And that is the sum of that, and Kimberly will take us out.
Yeah, thank you all. So I was asked to kind of touch on, so where do we see things going? And as I had mentioned earlier, the pandemic truly has had an effect upon our business, our designs, how we approach things, and particularly in the mental and behavioral health units. I mean, just a simple masking during the pandemic, those offered ligature risk, and many organizations were very perplexed about how to approach that. So some changes that we've seen through our practice and some of the conversations that we have been having has to do with the social area, how much space is allocated per patient, the group room sizes. Previously we had, approached 12 patients at a time. Maybe those numbers are reduced. How are meals being served and offered on the units? Some of the organizations that we work with had to relegate to eating in their bedrooms, and that caused a lot of anxiety and concerns for the staff in order to how to navigate that safely with the patients. And so there's just been a whole host of conversations and responses to design, but I think the one that I think too that have had the most influence on the designs moving forward has to do with the on-stage, off-stage concept that is developed in the med-surg. We are now seeing the benefits for that in the mental and behavioral health environment, so that we limit the introduction of staff and visitors into the unit. particularly the staff of the support system. They're not trained to be around mental and behavioral health patients. So having an offstage access point to where they can do their job, they can bring their supplies is a real plus. That's not always achievable, but to strive for that. Also, to take those carts out of the environment for the patients, both from a noise standpoint, from a safety standpoint, really is a good thing to do. And the second item that we're seeing that's really influencing the design is breaking down the units into smaller clusters of patients. You know, a pod kind of concept. So when you have a unit of 24 to 30 overall beds, that you break that down into smaller segments so that all the patients are not co-located together, and you have the ability to co-locate like diagnoses. You can isolate patients if you had an infectious condition. And I mean, put yourself in the patient's shoes. To be put into a very large unit, it's got to be frightful for you. So if you're in a little smaller cluster that you become familiar with those patients that are around you, you have a little bit more confidence to the environment that you're in. But there are many, many aspects. The open closed staff station, that is the future conversations. You know, we truly want the staff out in the unit, in the milieu, but how do you do that safely? There are lots of, how do you protect the staff as they're doing heads down work, and how does that really work and with all the equipment? So there are many, many conversations to be had. But thank you all today for the opportunity just to give you nuggets of a very complex project type, and for the dignity and safety of our loved ones.